Good afternoon, everyone. My name is Daphne Seriatis, and I'm an associate with CAQH CORE. Welcome to our September Town Hall. We have a lot to cover during this session. We will start off with an overview of CAQH CORE and federal activities, then walk through our initiatives on value-based payment, connectivity, and attachments, and then review our pilot and measurement initiatives. Finally, we'll conclude today's session with a questions and answers period. Before I hand the call over, I would like to mention a few logistical items. A copy of the slides and the webinar recording will be emailed to you tomorrow afternoon. However, you can download the slides now on the GoToWebinar dashboard on the right of your screen. I also want to encourage you to submit your questions at any time during the webinar by typing them into the questions panel on your dashboard. So let's get started. I would like to introduce our first speaker, CAQH CORE and Exploration Senior Vice President, April Todd. April?
Thanks, Daphne, and welcome everyone. I'm hoping you're having a good afternoon and that all of you are, you and your families are safe and healthy during this time. Before we get into some detailed updates for CORE, wanted to just do a brief overview for some of you that may be new to CORE joining the call today, just an overview of CORE. CORE, we are an industry-led organization. Our participants represent providers, health plans, vendors, government entities, associations, and standard-setting organizations. We're very proud to represent a very large segment of this stakeholder base and work on our mission to create operating rules and work on adoption of operating rules to improve standards and accelerate interoperability. We do this by engaging with participants all across the industry in a variety of activities to help more effectively and efficiently use standards and technology. As part of this, we have a designation as the National Operating Rule Authoring Entity for the HIPAA transactions for operating rules. And we are guided in this work by a multi-stakeholder board that includes representation from health plans, providers, vendors, government entities, and a number of advisors to the board from the SDOs and from WEDI. Go to the next slide. As part of the work that we do, this is a summary slide that shows the different areas that we have created operating rules and also areas that we are continuing to work on. So what you'll see on this slide is that we have operating rules along the entire workflow where plans and providers are exchanging information with each other. And these operating rules include areas related to infrastructure, related to data content, related to connectivity. Can you go on to the next slide, please? In addition to creating operating rules that help to make standards more effective and improve adoption, we also have a certification program. The CORE certification program is developed by industry, similar to our operating rules, and it's a way for organizations to verify and certify that they are conformant with the operating rules. We have a number of different organizations that have certified on a number of our operating rules and represent a very large share of the industry. Many health plans, for example, require their vendors to be CORE certified prior to contracting. And we have a number of vendor organizations on both the plan and provider sides that become certified. This year, as you'll hear a bit more about later, we also have started a recertification program where those that are certified will become recertified in those operating rules every 3 years. Go to the next slide, please. So to start off and provide an overview of things that we've been working on this year, which you will hear more about in more detail later in the town hall, these are the areas that were CORE's goals for 2020. And you can categorize them in 3 major areas. So the first area is around continuing to successfully serve as the National Operating Rule author to improve the efficiency, accuracy, and effectiveness of business transactions. For 2020, we focused on a number of areas. One of them was prior authorization, which you'll hear a bit more about later in terms of the operating rules that we brought to NCVHS this year. We have also worked on rules related to attachments, and that work has started over the past few months. That work will support prior authorization as well as claims and continue into 2021. We have also done work related to value-based payments, which you'll hear more about, particularly related to operating rules related to patient-provider attribution. We've also worked on connectivity rules, and these connectivity rules are intended to support some of the new rules that we have coming forward related to connecting administrative and clinical transactions. And we also have some areas of value enhancement that we have worked on as well. Some of this is related to some of the pilot work that you will also hear about later today. And the second area, this is an area where we have worked throughout 2020 to improve our certification program and improve adoption of the operating rules. We specifically have had targeted efforts to improve certification for certain components of our operating rules and for certain industry sectors such as Medicaid over the past year. And as I mentioned earlier, we also have launched our recertification program this year for entities to become recertified every 3 years on the operating rules. And our third area of goals is to continue to improve our integrated model and to create more stakeholder value in the work that we do. One of the areas we've focused on this year related to that is to transition from what we have historically done in terms of phased-based transactions and change that to a transaction-based approach to the rules that will make it easier for us to update those rules going forward. And lastly, we've also evaluated and launched some processes to more efficiently and effectively update and expand our existing rules as needed. So with that, if we can go to the next slide, I think we have our first polling question. Can hand that over to Daphne.
We'll take a brief pause in the presentation to hear from our audience. What business processes should CAQH CORE prioritize for operating rule development in the next year? We want to hear from you, so I'll give you all a few more seconds to respond before I share the results and ask April to give us her thoughts. April?
Great, thanks, Daphne. So it's interesting here to see the distribution there of interest in different types of rule sets. We seem to have some pretty evenly distributed areas for interest in rules, which it's not surprising to see a big interest in attachments and prior authorization. That seems to be an area that folks are very much interested in. The other thing that I would comment on is that we recently did a survey of our participants to gather information on interest in operating rule areas for 2021, which we'll share with you later in the year and early into next year. And these areas very similarly reflect some of the interest areas that we have seen in that survey. So thank you, Daphne. So next, before we get into some of the details of the operating rule efforts that we have been working on this year, wanted to provide a few updates of things that are currently happening within the industry as well. So first, in terms of a federal update, there are a couple items that are coming up here in the near term. The first one is the inaugural standards version advancement process. This was a component of the 21st Century Cures Act final rule. It allows health IT developers in the ONC Health IT certification program to voluntarily update their products to include national coordinator approved newer versions of the adopted standards. Comments are requested on this to help ONC understand which versions of standards are already in use in the health IT within the health IT community. The second update is related to the annual ISA, which is the Interoperability Standards Advisory. This is also requesting comments due by November 9th to provide information on comments, revisions, and proposed additions to the ISA that can be published within this advisory. This is really an area where the industry can go to find a dynamic, coordinated catalog of all the standards and implementation specifications that are used to help improve interoperability within healthcare. So I'd encourage organizations, if they have comments to submit to this, to look at the links that are within this slide and provide any comments by November 9th. We can move to the next slide. I also wanted to take this opportunity to also highlight some additional federal rules that have been passed this year and some work that is currently being done by CAQH writ large to help support the industry in complying with these rules. So earlier this year, CMS and ONC released to the market related to interoperability and patient access. And there are a number of components related to this rule. Some of them are effective in 2021 and others are effective in 2022. And these rule sets, they help support patient access to information from their health plans that can be available through third-party applications. They also require data exchange between health plans at a patient's request to help improve care coordination. So as these rules have gone into effect, ONC's Fire at Scale Task Force, Da Vinci, and a number of organizations have identified some things within the industry that could help accelerate adoption of FHIR and scale the adoption of these rules. And one of them is an endpoint directory that can help provide as a central source of information for validated endpoints for third-party apps and health plans to be able to connect to each other. So we can go to the next slide. One of the challenges that exists with these rules and where an endpoint directory can be helpful is that if you look at all of the different connections that could occur between plans and third-party apps, there's a significant amount of connections that would need to be established. And in doing that, there could be a significant administrative burden for each of these organizations to connect to each other. And to find out that information that is important for those connections related to security and privacy, conformance with standards, that could take those organizations a significant amount of time to do. So what we are working on, and you'll hear more about in the coming weeks and months, as I'll share on the next slide, is some work that CAQH has been doing to create a national centralized directory of payer endpoints that can be accessible by other payers as well as third-party applications. The intention of this endpoint directory is to allow payers to share information about their endpoints, including capability statements. It will allow payers and third-party applications to query each other's endpoints for multiple use cases. We would be validating the identity of payers and third-party apps, facilitating connection requests between those parties, and confirming the privacy and security of attestations, as well as ensuring conformance and validation of different FHIR endpoint use cases. And lastly, this would allow, in addition to health plans to upload their information, allow third-party apps to upload information about themselves as well to facilitate those connection requests. So this work is ongoing. We are engaging with a number of industry implementers and experts to bring this to market, and we anticipate having a beta launch of this in Q4 of 2020 with a full phase 1 launch in early Q2 of 2021. So with that brief industry update, I will hand it over to Erin, who will walk through some more specific details of the work that we've been doing this year.
Thanks, April, and thanks everyone for joining us today. I'm going to give a brief update on the National Committee on Vital and Health Statistics hearing that was held back in August related to the CAQH CORE Prior Authorization and Connectivity rule set. Next slide. So as April alluded to at the beginning of the presentation, in our role as the designated operating rule authoring entity by HHS, CAQH CORE can bring operating rules to the committee for potential recommendation for mandate under HIPAA. NCVHS is an advisory body to the Secretary of HHS on areas related to HIPAA and in particular operating rules. So the CORE board decided back in February actually to recommend a set of 3 operating rules for federal mandate, and the hearing was held in August. NCVHS accepted public comment via letter and also held a hearing where they heard feedback from industry stakeholders. CAQH CORE proposed 3 rules for federal mandate, 2 related to prior authorization, both the content of the HIPAA mandated 278 transaction and addressing the infrastructure of that transaction as well. In addition to a updated connectivity rule, which would apply to all of the HIPAA standards that have adopted operating rules, which are eligibility, claim status, and electronic remittance advice in addition to prior authorization. We anticipate NCVHS will finalize its recommendation to the Secretary at its November 18th and 19th meeting, at which point then HHS and CMS would make a decision as to whether to move forward on a federal mandate or not. I'll briefly review the content of the rules that were proposed to NCVHS. We have presented this information in several different education sessions at this point, so if you're looking for a deeper dive on the content, feel free to visit our website and listen to one of our previously recorded education sessions. These rules really do focus on addressing a pressing need to improve the automation and timeliness of the prior authorization process. The connectivity rule enhances the security and promotes uniform interoperability across administrative transactions. And the rules set the stage for future operating rules to further enable the convergence of administrative and clinical data and to support the use of new technologies with existing standards. The first rule that was proposed is the prior authorization data content rule, and this applies to the conduct of the 278 transaction, which is federally mandated under HIPAA. The requirements in this rule really help to improve and reduce common errors through patient identification and verification, require the receipt and processing of certain codes to enable auto adjudication through the support of a use case driven system and application design. The rule requires the return of healthcare service decision reason codes, which provide a clear explanation to the provider for the decision and inform the next steps. The rules require the use of certain codes to provide direction on status and what additional clinical information is needed, which is a critical link in the prior authorization process. The rules require specific error codes be returned to strengthen electronic communication and the detection and display of these codes to reduce the burden of interpretation on the provider. Next slide, please. The second rule that was proposed is the prior authorization infrastructure rule. For those of you that are familiar with these rules, you'll recognize a lot of these requirements as we have similar infrastructure rules across all of our business processes addressed by operating rules. So the requirements in this rule include a standard companion guide template to enable consistent access across trading partners, system availability expectations to enable providers to have an expectation of when systems will be up and running, the uniform use of acknowledgements to eliminate manual follow-up to determine the status of a prior authorization, processing mode and response timeframes to enable faster time to final determination, and safe harbor connectivity and security to ensure trading partners are capable and ready to exchange this data. Now, in 2019, the CORE participants updated this rule to include new turnaround time requirements, including a 2-day additional information request where a health plan has 2 business days to review a prior authorization request received via the 278 from a provider and respond with additional documentation requests to be able to complete that prior authorization. The second requirement that was added is a 2-day final determination. So once the health plan has received all the information it needs to make a determination from the provider, the health plan has 2 business days to send a response containing a final determination. And then thirdly, an optional closeout requirement where the health plan can choose to close out a prior authorization request if the additional information needed to make a final determination is not received from the provider within 15 days of communicating what additional clinical information is needed. The rule requirements are such that these timeframe requirements must be supported at least 90% of all of the prior authorization transactions. Next slide. The third rule that was included in the package was the CAQH CORE Connectivity Rule version C3.1.0. The prior federally mandated operating rules include connectivity requirements. These are previously known as our phase 1 and phase 2 requirements. These connectivity requirements are really outdated, so the CORE board included our latest version of the connectivity rule to align on a common transport message envelope security and authentication standards. So this would mean that all federally mandated operating rules would have the same connectivity requirements. Next slide, please. So this slide really just demonstrates where in the process these prior authorization requirements have an impact. So all the way from the point of service or the eligibility where the provider includes data to identify the patient on the 278 and specific information for a diagnosis code. Like a claim, the PA request includes specific data that the health plan must have to accurately adjudicate the process. As we move forward, I think there might be some animation in this slide. As we move forward, the health plan then acknowledges the receipt within 20 seconds or 2 days for batch, and continues to include some of these codes in the process as they go along. The information about additional documentation needs is included as the health plan returns specific error codes and other information to the provider, so the provider knows exactly what additional clinical information to submit. So that these rules play out throughout this process, and ultimately the final determination is able to be returned, and the entire process is done electronically, with the exception potentially of the exchange of attachments. Next slide, please. There's the animation that was missing. So the prior authorization and connectivity rules are available for adoption now through our core certification program. I just want to highlight here, we have several early adopters of the infrastructure rule and connectivity version C3, representing about 14% of the commercial marketplace now. So we really encourage you, as you're thinking through your budgets next year, to include core certification as a key component to help your organization demonstrate its commitment to improving the prior authorization process. And there's lots more information available on our website. Next slide, please. Finally, before I turn it over to the next speaker, I just wanted to highlight the benefits of the operating rules that were proposed to NCVHS. We have 2 case studies here related to the impact of some of the rule requirements. The first is a health plan, Harvard Pilgrim Healthcare. We had a lot of debate during the update of the infrastructure rule requirement around the response time requirements for prior authorization. In Massachusetts, there is a requirement that final determinations must be responded to within 2 business days, which really aligns with the core requirement. And so we know this is possible. We know that health plans can do this, and you can see some of the benefits that have occurred at Harvard Pilgrim Healthcare as a result of some of these requirements, including greater automation, use of the connectivity rule to help streamline the communications, reductions in FTEs, and also an increase in the number of electronic and real-time transactions. The second case study I want to highlight is Cleveland Clinic, who we worked with through our pilot and measurement initiative, which the team will speak more about later in this call. But they recently implemented a solution using the 278, the operating rules that intersected with their EMR workflow, prior auth now. And we worked with Cleveland Clinic and their vendor to measure the impact of this automation. And we saw significant reductions in staff time throughout the prior authorization process, with the exception of attachments. But what this really showed us is that organizations can still benefit from the use of the 278 and the operating rules, regardless of an attachment standard. So we did an entire webinar on this case study that is available on our website if you want to hear more about that work. At this point, I will turn it over to Lena to talk more about some of our other initiatives, but feel free to submit any questions or reach out to us if you're interested in learning more about our prior auth efforts. Lena?
Thanks, Erin. So if we can go to the next slide, please. So CAQH CORE has focused its value-based payments initiative on patient attribution. For those who might be unaware in the audience, attribution matches the individual patient in a population with a provider. And this method ultimately determines the patients with a provider, either the individual provider or the provider group, is financially responsible for. This methodology forms the basis of analysis for metrics underpinning VBP, such as total cost of care and quality measures. So while health plans supply attribution information on a regular basis, providers are often left with several questions. First question, why is this patient in my population? VBP contracts between health plans and providers may include information on the methodology, but the clinicians actually providing the care often don't have insight into those contracts and may not know why the patient is in their population, especially if it's a patient with which they've had no prior relationship. Second big question, who's on first? Patients can be attributed to a singular provider or a group of providers, and that can leave ambiguity as to who is actually the primary care provider, especially when it comes to situations where a patient might have a chronic health condition, such as diabetes or a cardiovascular issue such as heart disease, where they might see their specialist more often than they would their traditional PCP. And this might not be reflected in the attribution model. Third major question, who else is involved in this patient's care? In some VBP models, providers are penalized when patients visit providers outside of their network. Providers might not have insight into where else their patients are seeking care, and preventing leakage is a large incentive in VBP contracts. But without total visibility into patient utilization, you're often unaware that this leakage has occurred until after the contract period is ended. So provider success under VBP models requires knowing the answers to all of these questions. But before you can even ask these questions, providers need to know the answer to the most important question. Is this patient even in my attributed population? Next slide, please. So if you take a look at the current workflow when it comes to learning attribution information, when a patient schedules an appointment with a provider, the provider will send an eligibility transaction. And this eligibility transaction will be returned by the health plan information on the patient's financial responsibility, what their deductible and copay is, what services they're eligible for, et cetera. Once the patient receives the services rendered, the provider submits that healthcare claim, which would need to come back in order to not be financially penalized. Other things must go along with that healthcare claim, such as the completion of process or outcomes measures. And if a provider does not know that this patient was not attributed to them in the first place, the provider might not have met necessary information criteria and would fail to fully satisfy the terms of the VBP contract. All throughout this process, meanwhile, the provider is getting irregular intervals of Excel spreadsheets, emails, portal downloads of entire rosters of patients that they're supposed to sift through in order to fully understand who is within their population. Furthermore, since a provider works with multiple health plans, these can come across in various formats via various exchange mechanisms. Next slide, please. So in order to better enhance this communication between health plans and providers for the communication of attribution information, CAQH CORE has just two sets of operating rules. There are currently no industry standards for this exchange, and so the VP subgroup drafted these operating rules to reduce provider administrative burden and bring critical information to the point of care. The rule references aligning data standards, references aligning data across multiple standards, including FHIR. CAQH CORE has engaged with leadership from Da Vinci to make sure that we are aligned across the industry. The first operating rule is for single patient attribution status. So this will build upon the CAQH CORE operating rules for eligibility and benefits transactions. This data content rule will require that health plans send back within that 271 response the patient's attribution status. So is this patient attributed to the provider sending in this eligibility request? And the health plan must respond with that status, such as yes, no, partial, which would mean that the patient is attributed to the requesting provider as well as another provider and not applicable. The health plan would also need to send along effective dates of attribution. And if applicable, the health plan is encouraged to send along the contact information of the attributing provider when not the requesting provider to better enhance care coordination. The second rule set is for attributed patient rosters. So this rule set looks to streamline those multiple Excel files delivered at irregular intervals across health plans. This rule set contains one infrastructure rule and one data content rule, and standardizes the use of the X12 318 834 plan member reporting transaction for the exchange of patient rosters. The data content rule standardizes the minimum data elements a health plan must return to identify the patients in that population. This includes patient identifying information, as well as the VBP contract information and effective dates of attribution. And there's also an infrastructure rule that standardizes the expectations for exchange. So this is similar to our other infrastructure rules that standardize system availability requirements and companion guide requirements. But this infrastructure rule also requires health plans to send providers an updated patient roster, including updated dates of effective attribution, at least once per month. Next slide, please. So now when you have that draft rule, these draft rules actually implemented, the patient's going to schedule an appointment with the provider. And when the provider sends that eligibility and benefits request, the health plan is responding not only with that eligibility and benefits, that eligibility information, but also is confirming the attribution status of that patient. So when the provider submits the healthcare claim, they're submitting along all the additional documentation, including quality measure reporting, that is necessary for the health plan to correctly adjudicate that claim, and either provide an incentive reward or however that value-based payment model is being paid out. Furthermore, the provider then receives monthly patient rosters via standard format from all the health plans that they are involved in. So further simplifying the patient roster exchange as well. Next slide, please. So if you have any questions, please feel free to chat them at the team or contact us at core@caqh.org. And with that, I will pass it over to Emily Tenike, Core Manager. Emily?
Thanks, Lena. So what we want to do now is provide an update on the Core Connectivity initiative. On this slide, we see a comparison of the stages of core connectivity rules that have existed over time. And as we heard from Aaron, there are currently 3 published versions of the core connectivity requirements. And with the first and second versions of core connectivity requirements, which are federally mandated for core eligibility and claim status transactions, we really established HTTPS over the public internet and specified the use of SOAP and My Message envelopes, username, password, digital certificate for authentication. So really standardized transport throughout the security. But as mentioned, these requirements were developed over 10 years ago. So what version 3 does is that it really modernizes the requirements established in versions 1 and 2, those base requirements, by requiring single transport and envelope standards, more robust authentication and security measures by removing the use of username, password, and only requiring digital certificates, and then including specific metadata requirements. So as mentioned, this version is currently before NCVHS and applies to all transactions currently addressed by core operating rules, including eligibility, claim status, and ERA, and also adds support for prior authorization. And again, with the adoption of this version of core connectivity rules, we would sunset prior versions. So on the right-hand side here, and currently under development, is version 4 of the core connectivity rules, which will be an update to version 3 and will apply to all transactions addressed by core operating rules, including claim and prior authorization attachments rules that are in development. So this really is aiming to support clinical and administrative data exchange by adding requirements to support REST and other API technology. We'll focus more on the updates of this version 4 on the next slide. So in February of this year, the Connectivity and Security Work Group launched and was tasked with updating version 3 of the core connectivity rule requirements. And this group really identified 3 main goals for the update. And first, they wanted to align the core connectivity rule requirements to help support some of the frameworks proposed in the CMS and ONC interoperability rules. So some of the more technical specifications would align with where the industry is headed as it continues to progress. The second was looking at establishing and updating the core connectivity safe harbor requirements, making sure that we're supporting existing technologies such as SOAP, but always looking forward to what's emerging, like those RESTful APIs, to ensure that a safe harbor is able to support both standards that exist today and also flexible enough to support some of the more modern approaches in order to work to improve interoperability. And finally, as the work group thought ahead to these other core initiatives, particularly with attachments, which we'll hear about shortly, and value-based payments that Lena just went over, wanted to ensure that a single uniform core connectivity rule would be created to support the intersection of both administrative and clinical data exchange. So some of the specific updates to the core connectivity rule requirements that the work group is in the midst of developing is the use of TLS 1.2 or higher for increased security, looking again at those authentication and authorization standards. There's a lot of movement in the industry for OAuth 2.0, and then also looking at adding support, again, for the exchange of attachments transaction to support that interoperability between administrative and clinical data exchange. And finally, adding requirements pertaining to REST APIs. And again, there is a lot more information on this topic, specifically from a webinar in July. So please take a look at that if you have more questions. And I'll now hand the call to Bob Bowman, Core Director, to continue with a review of the Attachments Initiative. Bob?
Great, Emily. Thank you so much. And many of you, if you've been tracking with us for the last couple of years, you'll see that attachments has been, you'll know that attachments has been one of our biggest initiatives that we've tackled. We've been really working on this for the last couple of years because of the administrative and clinical burden that it places on providers and health plans. For us, attachments means a couple of different things. It really is that additional patient-specific medical information or supplemental documentation. It really could just be a piece of data, or it could be a true physical type of attachment that we're used to, right, as we fax in this information to health plans to support either claims or prior authorizations or audits or any number of use cases. No matter what, though, what we've seen and what our environmental scan and what our white paper has found is that these are awfully very highly manually sent and received by the stakeholders in this exchange, right? They can come in electronically, partially electronically, manually, right? Many providers receive letters requesting attachments to be mailed in, right? So that type of environment is really all over the place, and providers are really stuck with the variety. Right, there's many different types of standards and specifications used if you're going to do this electronically, both from X12, HL7, many different types of connectivity methods, as Emily mentioned. We're working on a couple of them, but there's even way more than those. So how does it impact the provider? Well, very negatively, as well as the entire industry, right? The entire economy is, health insurance industry economy is impacted by this incredible burden that providers and health plans have in in tracking and trending and understanding what this documentation is. So we've launched an attachments subgroup in July of this year, and the subgroup is working on its first use case, which is the prior authorization use case. We will follow that with a claims use case early next year. As you see there in our note, the attachments NPRM was expected to be published potentially in September. September's not over just yet. I haven't seen anything out there yet today, but we will be tracking this as well, because if the government does issue some sort of NPRM, we want to make sure that we're part of that process. Just as April mentioned, and Aaron for that matter too, the NCVHS is really important, and we work with NCVHS. We send our operating rules up to NCVHS for consideration, and what this subgroup is doing is just that. We're developing operating rules for attachments. So we go into the next slide, you'll see that we do have some really good headway that we've made on this topic. We've looked at, again, from the work that are from our environmental scan, our white paper, to our advisor group, and now to the subgroup, which is where we get into the details, right? They're actually writing and drafting rules around the exchange formats, for example, for an X12275, or for other formats as well, right? Potentially a CCDA. Infrastructure, we look at the infrastructure. How is the best way to communicate these attachments electronically between stakeholders? So acknowledgements, response time, processing modes, and system availability are key to laying that foundation for the conduct of any data. We also look at data content. The subgroup is looking at potential data error handling, right? If a message comes in, if an attachment comes in from our provider and the health plan has the capability of stopping it at the front door because the health plan knows it cannot process that data, or there's errors with that data, it's best to stop it at the front door, send back a message to the provider, so the provider understands that there's going to be issues and they can address those. So that's part of data content, along with reassociation, right? If you send in a 278, it gets pended, and the response comes back from the health plan that there's a specific pins for a specific piece of data or specific attachment, part of the medical record. The provider needs to know that, and they need to reassociate the attachment that's coming in with that original request. There's mechanisms to do that within the standards sometimes, and sometimes there's not. So the data content is going to be really important for that as well. So we're looking at that. Aside from that, there's other things that we're looking at besides, including master companion guide template, attachments, policy access. Other work groups and subgroups are also working. As Emily mentioned, we have our connectivity work, looking at different mechanisms to transmit the data, as well as our prior authorization work related to the structured data and code sets and timeframes, as Aaron mentioned. So all this work is taking place right now. So again, if you're interested in this work, please join us, come be part of those conversations. We're always looking for core participants to help us out. If we move over to the next slide, you'll see that we also have a pilot and measurement initiative. This is something that we kicked off last year and has really been helpful for us as an industry in learning where some of the biggest challenges are, and then how can we address them with operating rules and with standards. On the next slide, you'll see that this really is a way for us to work within the industry in finding the right folks at the right time, right? We do play Cupid, we play matchmaker. We try to get those folks together and really look at where they're at on an existing project, right? So maybe they're implementing something that's trying to automate the prior authorization process. It might just be a part of that process, but give us a call, let us come in. We can help set up and track and trend data. We can work with your staff in both organizations, if it's a provider and a health plan working together on this, or if there's vendors associated with it. Aaron mentioned our Cleveland Clinic and our PAN, our prior authorization now vendor. We had a great webinar just a few weeks ago addressing the pilot measurement study that we did with them. We're still looking and we'll continue to recruit participants to work in our prior authorization. It is an ongoing initiative. Again, we're always looking to find folks that are looking to better automate and better lead to those lessons learned and ROI study kind of components that really makes the operating rules and the standards really reach that tipping point of where we can go and approach NCVHS and HHS with real world findings. That's the important part, right? Here's what the industry is doing on its own organically, putting together the standards and the operating rules, implementing those maybe on a one-to-one basis, but still those findings are really important. And we are also launching a new initiative in 2021 On the next slide, there's actually some more detail related to the quality measures reporting. As Lena providing an update on VBP, this originated from our VBP work that we've done. And there's a large challenge here too for the administration and the burden that it has as providers submit lots of data to health plans related to the quality measure reporting. Today, one of the best ways that a provider communicates with a health plan is through the submission of a claim. But claims today do not actually capture many of those outcomes of services that were rendered to a patient. But is there a way to leverage some of those gaps in reporting within the claim process today, within that workflow? It would really help ease the burden on providers if they can support, for example, using extended different code sets within the healthcare claim to convey that non-service related clinical information that really can support much of that outcome measurements, those progress measures that they're required to report. So there's a way to look at a use case that's in place today, right? Claim submission, one of the primary purposes of the administration of healthcare today, using that type of reporting to help support value-based and quality measure reporting. That's what we're looking at as a potential initiative for next year. So again, if you're interested in that work, please reach out to us. We'll play matchmaker again and help you get tied into this process. I do want to back up just a little bit on the next slide. So we do have an engagement model that we use with any participant in one of our pilot initiatives or in our measurement studies. Again, we work with the industry, we identify those participants, we play Cupid, we matchmake them together. We, CAQH CORE, we really act as kind of as a secretariat. We look and work and we set the meetings and we document things and we try to find an exact, we capture the current state and the future state. Here's where your technology is being plugged in at. Here's where your business processes are being adjusted. Here's how you have to track and trend that. So we design and run a very specific study. We capture the data. We analyze that data. We look at all the different points and the measurement points that have been tracked and trended. And then we share and report that with the industry. Again, as I mentioned with Cleveland Clinic and PAN, we were able to share that great feedback from the industry on the lessons learned, what kind of return on investment both organizations had, what was the impact to providers, ultimately giving a positive impact for the delivery of healthcare into the patient itself, to him or herself. So again, we can plug this into any sort of existing project within your organization, right? You may already be doing prior authorization. I bet you are. Help us help you so we can help track and trend what the real value are and what time savings you can have by tweaking few things, right? A little technology here or operating rules here, expectations with this trading partner or with this health plan. This health plan's maybe more progressive and wants to work with you directly. We can help kind of bring that together. Again, existing projects are part of that package, as well as any sort of new implementations. Let's say you are looking at a vendor to help with your prior authorization process or with your VBP process. The reporting burden has become so much, you're looking for a third party to help you. We can help identify some of those folks, again, and play matchmaker, and make sure that you're getting the benefits that you anticipate. We can help you track and trend for those benefits. And then again, share that with the industry and make it a way for us all to learn from kind of the best in class, the best in show, the best way forward for those types of organizations that share the same impact that you're looking for. With that, I'll hand the call back over to Daphne for our last polling question. And again, we do have a Q&A session for the last few minutes of our call today. If you haven't had a chance to enter in a question, please take the time now to do so, as well as address our last polling question. Daphne?
Thanks so much, Bob, for the overview and perfect segue into our polling question. We want to gauge initial interest in the Quality Measures Reporting Initiative. Please let us know if you're interested, and a member of our staff will reach out to you with more information. So I'm going to go ahead and close our final poll and move us right along into Q&A. So our first question is on the NCVHS hearing. Erin, can you share some of the comments that various entities made during the August hearing?
Yeah, thanks, Daphne. I'm glad somebody asked that because I realized I forgot to talk about the actual hearing in my update. You know, we heard a lot of alignment in the comments during the hearing and also in the comment letters as we did during the core rule development. I would say the majority of letters and feedback were very positive and supportive, particularly from the provider stakeholder group. You know, the industry is definitely looking for some guidance on attachments as well as prior authorization. That was probably one of the biggest themes in the feedback. So thanks for checking in on that, Daphne.
Thanks, Erin. Our next question is, why was priority placed on working on the prior auth attachment first before the claim attachment, given that there's more volume on claim attachments? I'll open this up to the group.
This is Bob. I'll take a first stab at it. Part of the reason why we went first with prior authorizations in regard to attachments is that it segued really well with the work that we just completed with prior authorization. We just finished an update to the previous rule related to data content and infrastructure for the 278. So a lot of the participants and a lot of the work and findings that we had in those previous two initiatives really segued really well with the attachments work. And again, we did kind of track these PA first and then claims. Much of what we find in prior authorization will be exactly corollary and parallel to what we will find in claims, especially related to the conduct of the 275, for example, or the CCDA transaction or as well. So I think that it's not necessarily a priority. It was more of just a natural segue from the work that we had just completed on prior authorization. And I think also some of the work that we have planned for next year really segues well and works well, is congruous with the work that we plan on claims. Again, with value-based payment and looking at different coding structures there to help support VBP and potentially attachments related to that can be important for the conduct of the 837 of the claims transaction. So they'll actually work pretty well in parallel.
Thanks, Bob. I'll shoot another question at you. Are we including small physician groups and individual physicians in the pilot project?
Oh, that's a great question. Yes, emphatically yes. I think that any entity that is working on different segments just like that, it's really important to get their perspectives as well. So small plans, small vendors, small providers, IPAs, TPAs, those types of perspectives are really important because they are probably more overly impacted by regulations. And if we can work and understand how even small changes to workflows or business processes or technology can have a greater positive impact, a better ROI for them, it really helps us go kind of sing that to the rest of the industry. So we actually look forward to working with those types of organizations and entities to ensure that we get those perspectives.
Thanks, Bob. And we have another question on the CAQH index. Do we anticipate having data on pharmacy transactions for the 2020 index?
This is April. I can probably answer that one. We just here, this is our initial year in starting to ask the pharmacy industry related to the index. We have some initial results that we hope to share soon that will be separate from the index, but we do look forward to incorporating pharmacy components into the index going forward. They will not be in the 2020 index, as we'll look to continue to report them separately in the next year, but in the following years would look to combine them into one survey.
Thanks so much, April. And with that, we can wrap up our Q&A session. We hope you'll join us for our upcoming events. Our next webinar on October 15th is a collaboration with LEDI and the CMS National Standards Group, and will be an overview of the HIPAA standards exceptions request process. For those of you attending the WEDI National Conference on the 16th, we will be holding a pre-conference session on our attachments. We wanted to share some of the benefits of joining CAQH CORE as a participating organization. One of the most meaningful parts of joining CORE is that you help drive these rule development efforts that really help bring the industry forward. These initiatives that we highlighted today would not be possible without all the energy and collaboration of our participants. I want to thank you for joining us. Once I end today's session, you'll see an end of the webinar survey. I know that we went through a lot of topics today and we want to hear your feedback and questions. Additionally, please feel free to email us at core@caqh.org if you'd like more information on the operating rules or any other CAQH CORE activities. Have a great rest of your day.